Good morning everyone, I am Kaveri and today I will be presenting my two bilateral ptosis cases with distinct genetic etiologies. If you see the first slide, the presentation is mostly similar, but the key is not in the looks but the story that shall unfold. My first case is a 5-year-old male who presented with the chief complaints of drooping of both upper eyelids, which was noticed at the age of 1 month. The parents noticed drooping of both upper eyelids, which was symmetrical and varied in extent throughout the day. And they noticed that it improved when the child woke up from sleep, and it was associated with chin lift. There was no history of double vision, no history of trauma, and no history of prior similar episodes. Since the child was admitted in ICU for pneumonia twice, we went ahead with an ENT evaluation and no significant abnormality was found. The child was in full-term normal vaginal institutional delivery born out of a non-consanguineous marriage. The important part was that he had a elder brother with a similar complaints. The best corrected vision was 6/6 in both the eyes, and the head posture, he had a chin lift. Coming to the eyebrows, there was uplifting of the brows indicating a frontalis overaction. There was presence of lid crease. The palpebral fissure was 28 into 6 mm with an MRD1 of 1 mm. There was no pigmentary retinopathy, and the rest examination was within normal limits. The photo depicts the same. The ocular movements were restricted in all the gazes. Because of a high clinical suspicion, we went ahead with the ice pack test and it was found to be positive. We even went ahead with the Kogan lid twitch test, and if you notice carefully, there's a twitch when he looks upwards. The second test that we did was the curtain sign test, and when you see the right lid is elevated, the left lid droops. We went ahead with the blood investigation and we found out that antibodies for acetylcholine receptors were negative. Again, with our strong clinical suspicion, we went ahead with the genetic testing, and we found that the pathogenic variants in the Cherney gene were positive, indicating congenital myasthenic syndrome, and the inheritance pattern is autosomal recessive. We managed the case with PEDS and with tablet pyridostigmine and syrup salbutamol. Salbutamol is the important part here. It is usually seen to benefit patients who have DOX7 mutation, but here also it benefited the child. Our second case, and a more interesting case, is of a 30-year-old female who presented with drooping of both her upper eyelids since birth and inability to move her eyes in any directions, which was noticed at the age of 6 months. Her parents reported the same complaints, and again, since the early school years, the patient has found it difficult to climb stairs. In the past few years, she also noticed that her hand grip is also becoming weaker. There was no history of double vision, no limb pain, no loss of sensation, and the patient is a regular glass wearer. The pedigree was the interesting part, that the patient was born out of a consanguineous marriage to maternally related parents, and all 3 siblings were affected with similar complaints and similar age of onset. On ocular examination, the vision was 6/12 in both the eyes, and again the patient had a chin lift. The lid crease was absent, the palpebral fissure was 28 into 3 mm, and MRD1 was -2 and -1. The corneal sensations were also decreased. The deep tendon reflection tone was grossly normal. The ocular movements were restricted in all the gazes. So coming to the ocular ophthalmic examination, this is a patient of a bilateral congenital ptosis with total external ophthalmoplegia and with normal fundus. We went ahead with MRI, repeated nerve stimulation tests and EMG studies. There was no decremental response in RNST. The acetylcholine receptor antibodies too were negative. Our differentials in our mind were CPEO, Kern-Sayers and myasthenia. Going ahead, we went with a genetic analysis, and the interesting part here was we found that there was the mitochondrial gene panel was negative, but the TTN gene missense variant was found. The diagnosis of a titin gene associated bilateral ptosis with ophthalmoplegia born out of a consanguineous marriage with all siblings affected with upper and lower limb weakness was made. And surprisingly, this is the second case which has been reported. The first case was published maybe in 2023. So what was the treatment? We did genetic counseling for the patient. Crutch glasses were offered, keeping in mind that the patient lubricates her eye frequently. Cardiac monitoring was done because titin is also associated with cardiac muscles, and neurology opinion was taken. What is the takeaway? That bilateral ptosis is not always a surgical problem. It's an etiological one. Identifying the underlying cause is the key. In Cherney syndrome, pharmacological therapy works wonders. And in the second case, the symptomatic treatment and genetic counseling was the most important one. Thus, the right diagnosis shapes the right therapy. Thank you.